Hello, and welcome to our live webcast, Progress in Amyloidosis Research. Where are we now? Thank you for joining us. My name is Tyler, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. During this presentation, you will see the following multiple-choice polling questions during the event. To participate in the polls, please select the buttons or to the left of your answer that best represents your views or experiences. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we do ask that you complete a brief post-event survey. Please take a moment to complete this survey as it will help amyloidosis plan future web events. We are joined today by our speaker, Dr. Jeff Zonder. Jeffrey Allen Zonder, MD, is a professor in the Department of Oncology at the Barbara Ann Karmanos Cancer Institute at Wayne State University School of Medicine. He received his medical degree from Wayne State University School of Medicine. He completed his medical residency at the University of Rochester in Rochester, New York, before returning to Wayne State University for hematology-oncology fellowship training. Dr. Zonder is the leader of the KCI myeloma and amyloidosis multidisciplinary subteam, a medical advisor for the Amyloidosis Support Group Networks, and a member of the International Myeloma Working Group, the International Myeloma Society, and the International Society of Amyloidosis. He is a member of the American Society of Hematology, the American Society of Clinical Oncology, the American Medical Association, and the SWOG-Barloggy-Salmon Myeloma Committee. He was the national principal investigator of the SWOG study S0232, a randomized trial that helped establish the efficacy of lenalidomide and dexamethasone as initial treatment for myeloma. Dr. Zonder has authored or co-authored numerous original research papers, review articles, book chapters, and research abstracts on myeloma and amyloidosis. Dr. Zonder chaired 2 Untangling Amyloidosis Friday satellite symposia at ASH in 2015 and 2018, founded the online Amyloidosis Journal Club #AmyloidosisJC, and regularly participates as a speaker at the amyloidosis patient support groups.
Hi, everybody. This is Jeffrey Zonder from the Karmanos Cancer Institute in Detroit, Michigan, and I'm happy that you're joining us for this recorded webinar called Progress in Amyloidosis Research. Where are we now? This is brought to us by the Amyloidosis Foundation in collaboration with Amyloidosis Support Groups, Inc. Here are my relevant disclosures for your information. And here are our objectives. The first thing I want to do is to describe the typical pathway that clinical research follows as we're trying to develop new therapies. We'll talk about the preclinical stage of drug development and then the various phases of clinical development of a drug. And then we're going to discuss the latest clinical advances in amyloidosis research, and I'm going to focus largely on AL amyloidosis, which is also called light chain amyloidosis, and ATTR amyloidosis, which is also called transthyretin amyloidosis. And I'm going to try and put each of the developments that we talk about in the context of where they are on the research pathway that we talked about before that. So here are the phases of drug development. Preclinical testing is laboratory testing by and large, and it can include animal testing. And this is the work that's done to establish to validate the rationale for using a particular drug, testing a theory and making sure that a compound does what we think it does in cells and that it's also tolerated and there are no safety signals in animal models before we start testing it in human beings. After this stage is done, the drug is approved for clinical testing, and then it can enter phase 1 testing, which is typically first in human testing. And the graphic here shows us that these are typically smaller trials, sometimes with as few as 15 or 18 or 30 patients, and typically different groups of patients are treated at different dose levels. We start at very low dose levels of a drug, and once we establish that that dose level is safe, usually in 3 to 6 patients, we escalate to another dose level, and then once we determine that's safe, we escalate to another and another, sometimes to a predefined maximum dose, and sometimes to what we call the maximally tolerated dose, which means the dose level at which there isn't unacceptable toxicity in the patients who are getting it. In trials like this, sometimes each group is treated the whole time they're on the trial at the dose level they start at, and sometimes there's escalation for the patients who are initially treated at low doses. Once we have proved that higher doses are tolerated, we allow those earlier patients to have their dosing escalated to the higher and still safe doses. A different type of phase 1 trial, which is relevant in amyloidosis, is testing established drugs, but testing them in new combinations or new dose levels. And it's to make sure that the drugs are as safe in amyloid patients as they are in patients with other conditions. And that's specifically in the case of AL amyloidosis. We're typically talking about chemotherapy drugs that we already use to treat multiple myeloma or other cancers. And what we do in that situation is back the dose down a little bit, make sure it's usable in amyloidosis, and then escalate from there, if possible, to the standard doses used in other conditions. Now, once that sort of testing is done and safety of a drug or drug combination is established, we move to phase 2 testing. And there's lots of different types of schedules, and the graphic here is supposed to show 2 different types of trials. At the top, I'm showing an example of just a straight phase 2 study where a larger group of patients, sometimes a few dozen, sometimes up to 100, are all dosed at the same level and simply treated to see how they respond for as long as they respond. That's called a single-stage phase 2 study, but there are other examples, more complicated examples, such as the second graphic, which enrolls patients and enrolls a certain number of patients, treats them to see if there's a response, and then based on the response rate in that smaller group of patients, a yes-no decision is made about going forward and enrolling more patients or stopping the study because we're not happy with either the efficacy signal or perhaps the safety signal. Now, after that, that's when we get to the clinical trials that typically lead to approval of a drug, and that's a phase 3 study. Phase 3 studies are usually randomized trials, sometimes blinded, sometimes not blinded. And what blinded means is that the patient and or the physician treating the patient are unaware of what therapy the patient has been randomized to. This is a head-to-head comparison of new therapy versus standard therapy. Typically, these kinds of trials are designed with consideration of what kind of efficacy one would need to persuade the FDA that the drug is worthy of approval. After these studies are completed, the data is reviewed by the FDA, and if the results are promising or are deemed satisfactory without any new safety signals, that's when drugs are typically approved. Phase 4 trials are usually ongoing surveillance trials that are done after a drug has already been approved, and it's basically a way of gathering long-term safety information, and long-term efficacy information. And occasionally these phase 4 trials are the ones that turn up rare but important side effects that weren't obvious earlier in the development of the drugs. So with that background, I want to move into the subject of AL amyloidosis and talk about some advances in that subtype of amyloidosis. We should all remember that AL amyloidosis is a plasma cell disease. Plasma cells are the cells in your bone marrow. They're part of your immune system, which make antibodies. Everybody has plasma cells in their bone marrow, and there's two basic types of plasma cells, kappa plasma cells and lambda plasma cells. And we can distinguish between those based on the kind of antibodies and light chains that they produce. Light chains are fragments of antibody proteins, and in this picture here, you see a group of plasma cells, some kappa, but a lot more lambda, because the lambda cells in this particular case are the abnormal ones. There's an abnormal clone of lambda plasma cells that have sort of overgrown the other mixed lambda and kappa cells in this group. And what you can see is that there are light chains being secreted by these cells, and there's an excess of lambda light chains. There's about twice as many lambdas as kappas in this particular picture. And the lambda light chains are the abnormal, dangerous, misfolded light chains that eventually turn into amyloid in your body. Now, amyloid amyloid formation is a multi-step process. These free misfolded light chains, which we can measure in the blood using a free light chain assay, start to form small clumps that are still floating around in the blood. The medical term is soluble oligomers, but think of them as clumps that are starting to form, and then these clumps aggregate further and they turn into fibrils or strands, and these are not soluble and circulating in your blood anymore. These get deposited in your body tissues and can affect the function of different organs. We are fairly certain that both the clumps and the strands are toxic to different body tissues. And so the strategy of targeting the plasma cells is sort of like shutting off the tap. It's you're closing down the production of these light chains so that downstream formation of these toxic species can't continue. So again, to review, and I want to make sure that we all understand light chains well, there are two types of light chains, kappa and lambda. And in AL amyloidosis, because there's an overgrowth of cells that make either kappa or lambda, there's an excess of one or the other. The bad light chain, the one that forms amyloid, in the last example it was lambda, and it usually is, but not always. The bad light chain is called the involved free light chain, and we abbreviate it like you see here, IFLC. And then the normal light chain, the one that doesn't form amyloid, is called the uninvolved free light chain, and that's abbreviated UFLC. The goal is to reduce the level of the involved or amyloid-forming free light chain. We target the plasma cells to do that. When you see a report of your light chains, what you'll see is a kappa light chain level, a lambda light chain level, and you'll see the ratio of one compared to the other. And that's helpful, but we are even more concerned about the difference. So if you subtract the value of the good light chain from the bad light chain, you get the difference between the free light chains, DFLC, and the difference between the free light chains is how we measure response. Here's a picture that explains that. So here in this example, the involved free light chain level in pink is higher, much higher, than the level of the green bar, which is the uninvolved or non-amyloid forming light chain. And the difference between these is measured here on the far left, DFLC, difference between the free light chains. Now, as we're treating somebody with therapy that lowers the plasma cells and the light chains, reduction in this difference is how we grade responses. So if you knock that difference down by 50%, as shown here in the second bar, we call that a partial response. If you knock it down even further than that, and the difference is suppressed to a difference of less than 4 milligrams per deciliter, or if your lab uses milligrams per liter, 40 milligrams per liter, that we call that a very good partial response, or a VGPR. And if you can actually knock the involved free light chain down to normal levels, and there's no particular difference between the two types of light chains, we call that potentially a complete response. We also actually need to do a bone marrow biopsy in that situation and prove there are not any abnormal plasma cells in the bone marrow anymore, but you would only do that if you've gotten the light chains down into the normal range like this. The red arrow at the bottom indicates that we consider any kind of a response that's a VGPR or better to be an adequate response. We like to see complete responses, but even a very good partial response is associated with improved outcomes compared to lesser responses. So here we have a table of different therapies we can use to try to target the plasma cells. We have 6 different columns, which include a variety of different types of drugs. The pink, green, and purple columns are traditional anti-cancer drugs, and all of them are important in treating multiple myeloma, a related plasma cell cancer, and they've been adapted for use in amyloidosis. The blue column is steroids, and dexamethasone is the most common steroid used, and that helps the chemotherapy drugs work better, but has to be used carefully because of the side effects of the steroids. And then in the columns on the far right and the far left, these are newer agents. On the left, the orange column, antibodies against plasma cells. The top one, daratumumab, also called Darzalex, is a particularly important new drug that I'm going to share some data about a little bit later. But let's go back to the columns that are chemotherapy or steroids. Typically, we don't just pick one drug from one column and try and treat a patient with that. Usually what we do is we select different drugs from different columns and combine them into a regimen. So, for example, a common regimen that we use in AL amyloidosis is Cy/Bor-D. And what is Cy/Bor-D? Cy/Bor-D is shown here. It's really one drug from the purple column, the alkylating agent Cytoxan or cyclophosphamide, that's the Cy. A drug from the proteasome inhibitor column, bortezomib, Bor, that's also Velcade, that's what many people know it by. And then the D in Cy/Bor-D is dexamethasone, which is a steroid. So it's one drug from one column, one drug from another, and a third drug from a third column, and together the acronym Cy/Bor-D is basically an abbreviation for the 3 drugs that are used. And typically when we use chemotherapy drugs to treat AL amyloidosis, we give repeating cycles of therapy. The schedule for each cycle varies, but a cycle is usually 3 to 4 weeks in length, and we repeat the drugs for several cycles until we get to a maximum response. Now, the one exception to what I just told you about combinations is in the middle of the purple column, and that's IV melphalan. IV melphalan is an alkylating agent, but we use high doses of it, and we use that only before an autologous stem cell transplant. An autologous stem cell transplant is a way of safely delivering an extremely high dose of chemotherapy that the amyloid plasma cells can't resist, but because it's intensive therapy, only patients who are sufficiently healthy can actually have that therapy. And that's typically younger patients and patients with preserved heart function, and preserved kidney function. So what we have here is a phase 3 study that actually compares the strategy of high-dose chemotherapy with autologous stem cell transplant, that's what ASCT stands for, versus standard dose chemotherapy. And this is an example of a phase 3 study because we have newly diagnosed AL amyloidosis patients being randomized 50-50 to either high-dose therapy with transplant or standard chemotherapy. And patients were followed until their amyloidosis progressed. And survival for the groups was compared, and at the bottom we see a survival curve, and disappointingly the high-dose chemotherapy arm actually did worse in terms of average survival than patients who got standard chemotherapy. And the median survival was only 22 months for the transplant group versus 57 months for the non-transplant group. And this was disappointing for a lot of reasons, but the main reason was that there was a lot of optimism that because transplant would be more effective at clearing the plasma cells, that we would have better outcomes. In reality, what happened in this particular study was because of the way patients were selected to participate in the study, some of the patients did not meet what would be considered current standard criteria for stem cell transplant. And because not all of the patients were really as fit as a typical stem cell transplant patient would be in 2019, there was excess toxicity for those patients. And as a result of that, there was more upfront complications and more mortality than we normally expect now. When you look at series of patients from the Mayo Clinic or Boston University or other centers that do large numbers of transplants in the last decade, the survival is significantly better than this, and it has to do with better management of side effects and also more careful selection of patients for transplant. A lesson that we can take from this is that even if a therapy is, quote, more effective than the other therapy, it's only more effective if patients can actually tolerate it. You have to be able to safely deliver the therapy to get the benefit from it. So early mortality, which means a high rate of death early on after a diagnosis of myeloma, is not limited to transplant. Even on that last, in that last example that I just showed you, there was a significant drop-off on the survival curve for the patients who didn't get high-dose chemotherapy. And it's because a lot of times by the time patients have been diagnosed, they already have advanced organ damage, particularly in their heart, and this puts them at high risk of having fatal complications from the amyloidosis at the outset, even as we're starting therapy. So here we have the results of a different phase 3 study, a newer study, and it's not a transplant study. This is newly diagnosed AL amyloidosis patients with the highest cardiac stage patients excluded to minimize risk of early cardiac complications. And in this phase 3 study, patients were randomized to either melphalan and dexamethasone, which, if you remember, was the winning arm from the other study I just showed you, versus melphalan, dexamethasone, and a third drug, Velcade, which is also called bortezomib. And these patients were treated in repeating monthly cycles and followed until they progressed. And in this study, at the end of 3 cycles, 78% of patients in the 3-drug arm had had a response versus only 51% in the other arm. Now, any response means a partial response or better. If we want to look at the high-quality responses, the ones that I said we're actually targeting, you can see that the 3-drug arm was better in that respect too, with almost twice the very good or better, a very good partial response or better rate compared to the 2-drug arm, 53% to 28%. And here you can see a survival curve which isn't statistically different, but which may show a slight benefit favoring the three-drug combination. Cybor-D, the drug that I mentioned, the drug combination that I mentioned before, has also been studied and has been published. But really, all that's been published on this regimen are case series. Case series may sound like phase 2 trials because they're groups of patients who are all treated the same way without randomization, but they're usually not prospective, meaning the study isn't planned ahead of time and with patients treated following a certain calendar. It's more a situation where patients are treated with a certain regimen, and then later, at some point down the road, the investigators go back through their records and say, okay, let's round up all the data on the patients who are treated with regimen X or Y or Z, and let's just report how they did. And so the first case series of Cybor-D was actually just a 17-patient series from the Mayo Clinic, originally published in 2012. The regimen was studied because it's one that we've been using in the plasma cell cancer multiple myeloma, so we know that it's good at killing plasma cells. And in this 17-patient study, we saw a 94% response rate, which means 94% of patients had at least a partial response, and a 71% complete response rate. Now, this looks quite a bit better than what we were seeing with melphalan and dexamethasone in the larger studies, but that's probably a function of the very small numbers that were included in this particular series, because when we look at a later 200-patient series from the European Union published in 2015, what we see is the numbers coming back down to earth a little bit, a 62% overall response rate, with 43% of patients achieving at least a very good partial response. So these numbers are much more similar to what we saw with the combination of melphalan, dexamethasone, and bortezomib, and that's not really that surprising because think about the regimens. Bortezomib and dexamethasone are the same, and then in one version, Cytoxan, an alkylator, is being used, that's Cybor-D, and in the other regimen, a different alkylator in the same family, melphalan, is being used. So these are actually very similar regimens, and it's not at all surprising that you would see similar outcomes like this. So, taken together, if we consider melphalan, dexamethasone, and bortezomib, or Cytoxan, bortezomib, and dexamethasone to be the best three-drug standard non-transplant combinations, you can see that adequate responses, meaning a very good partial response or better, is only achieved at most about half the time. So we have a lot of room for improvement with newer regimens. So this brings us to a newer regimen, a new phase 3 study that's sort of still in process. This is Cybor-D plus or minus daratumumab, which, again, this is the standard Cybor-D, with some patients getting that plus an antibody called daratumumab versus patients just treated with Cybor-D. And this is a large randomized study that's still ongoing. Patients are treated for a total of 6 cycles with the combination, and then the patients in the daratumumab arm also go on to get ongoing daratumumab maintenance therapy, which means periodic doses of the antibody instead of just observation, and then patients are followed. We are in the midst of accruing patients to this study. It's ongoing, but what we do have is data from a safety run-in cohort, meaning basically effectively a phase 2 group that was treated with the study combination, the Cybor-D plus the antibody plus maintenance therapy, before we started the randomized study. And the reason for this is to make sure that this combination was actually safe and tolerated in patients with AL amyloidosis. We have a lot of experience using this antibody plus chemotherapy in multiple myeloma, and multiple studies have now shown in that other disease that adding the antibody to chemotherapy makes it work a lot better without excess toxicity, but we needed to make sure that that was also true in AL amyloidosis. So we did this phase 2 safety run-in that involved 25 patients, and once we were sure that that was safe, we then proceeded with the randomized portion, and that's ongoing. And here's the data that we have from the safety run-in phase. The 25 patients who were treated with the combination of Cyborg-D plus the antibody daratumumab had a 92% hematologic response rate, and of those, 76% of the patients had at least a very good partial response rate. That seems to be about 1.5 times as high as the VGPR rate in patients who are just treated with Cyborg-D. So this is very, very encouraging. Now, there were a handful of patients that had what we call infusion reactions. Remember what I told you daratumumab is? It's an antibody. It's an antibody that targets something on plasma cells called CD38. And antibodies are proteins. And when you treat patients with proteins of any type, there's the possibility of an allergic type reaction. And so daratumumab does require pre-medications to minimize the risk of those reactions. And what this safety run-in showed is that we were very successfully able to do that, because only 4% of the patients had infusion reactions, and they were all minor reactions. In terms of other common symptoms seen in this safety run-in, we saw diarrhea, edema, which is leg swelling, nausea, and anemia. Some of these certainly might be related to the chemotherapy, but it's also very important to know that adverse events in a clinical study could also be related to the underlying amyloidosis. And some of these problems, for instance, diarrhea and edema, sometimes are just complications of AL amyloidosis. And so not all of these episodes of toxicity, or not all of these symptoms were necessarily related to the treatment. So a take-home message from this to remember is that before you can conduct a phase 3 trial, there needs to be adequate phase 1 and or phase 2 data to support the safety and the potential efficacy of a new treatment, because the phase 3 trials first involve a lot of patients that you could be exposing to risk if you don't really have a good handle on the side effects of a regimen. And also, they're extremely expensive and time-consuming to do, and it's a major commitment for pharmaceutical companies, for clinical investigators, and for patients. So if you don't have at least a hint ahead of time that the therapy is effective enough to be worth testing against standard therapy, you need to get more data to prove that it is before proceeding. What else can I tell you about daratumumab? That's the antibody that I mentioned. We also actually have data to show us that daratumumab by itself is active in AL amyloidosis. So the trial that I just showed you, which is a phase 3 trial, was comparing the strategy of chemotherapy plus DARA versus chemotherapy alone. But we actually have several case series that show that daratumumab by itself is very effective in treating AL amyloidosis. We reported a case series of patients together with colleagues from the Cleveland Clinic that was composed of 20 patients with relapsed AL amyloidosis, and of these 20 patients, 15 of them were evaluable for response, and of those 15, 13 achieved a very good partial response. That's an 86% rate of very good partial response amongst evaluable patients. So very encouraging single-agent activity, actually somewhat similar to what we saw with the Cyborg-D plus daratumumab in newly diagnosed patients, but I don't want to make too much of it because remember, the original small study or small case series of Cyborg-D suggested a higher response rate than we eventually saw when we tested it in larger numbers of patients, and it probably simply had to do with small numbers of patients making it difficult to precisely estimate the efficacy. Now, we actually do have one prospective study now of daratumumab that's ongoing. Dr. Sanchrawala from Boston University did give us some preliminary data about 21 patients with AL amyloidosis previously treated, most of whom had advanced cardiac disease, and two-thirds of whom had already had a prior autologous stem cell transplant, treated with daratumumab according to standard dose and schedule intravenously. And what we see here, we call this a waterfall plot because the way the graphic looks like a waterfall, but basically the lines show the reduction of the difference in the involved free light chain from baseline, which is at the top, and the depth of the line going downward shows us how deeply we suppress or how deeply we reduce the difference between the involved and uninvolved free light chain. So the deeper the better, and the maximum that it can be is 100%. To help make it easier for us to understand what we're seeing, Dr. Sanchrawala color-coded these bars, and every bar here is a very good partial response. Every light blue bar is a partial response, and the red bars are less than that. So you can see here that out of 21 patients, 19 had at least a partial response, and 16 had a very good partial response. And the exciting thing about this is after just one dose of DARA. So this isn't the best response they achieved. This is the response they achieved after the first week of treatment. So it shows a high response rate, deep response rates, and encouragingly fast responses. And that's why we're so optimistic that adding daratumumab to other therapies is going to be a major improvement in the treatment of AL amyloidosis. It's not the only antibody being tested, though. We have the trial that I mentioned initially, the Cyborg-D plus or minus daratumumab as initial therapy. We also have another trial using isatuximab. That's a different antibody that targets the same protein on plasma cells as DARA, CD38. That's being tested as a single-agent drug in relapsed refractory AL amyloidosis patients through the Southwest Oncology Group. That's an ongoing phase 2 study. And then we also have a phase 2 study of the combination of lenalidomide, dexamethasone, and elotuzumab, a completely different antibody that targets something called SLAMF7 that is expressed on plasma cells. And this trial is also for patients with relapsed AL amyloidosis, and we're leading that trial. And this combination, lenalidomide, dexamethasone, and elotuzumab, is actually an approved combination in multiple myeloma, and we're testing it to see if it will be effective treatment for AL amyloidosis as well. This is a diagram of the design of that particular trial, and I'm showing it to you mostly because it's an example of the two-stage phase 2 design that I mentioned before. What we're doing in this trial is we're treating 10 patients with this 3-drug combination. They're all getting the same doses of drugs, but after those 10 patients are enrolled, we're checking to see how many responded. If at least 3 do, that's the go-ahead to enroll 12 more patients, and then we'll see what the overall response rate is for all 22 patients. If we don't get at least 3 responses out of the first 10 patients, we're going to cut the trial short because the efficacy of the regimen isn't in the range that we want to see to justify further development or exploration of this regimen. So, What about even newer agents? So far we've been talking about agents that only target the plasma cells, again, shutting off the faucet or turning off the factory. By doing that, we reduce light chains. What about the strategy of just not worrying about the plasma cells, but using therapy which actually just takes the toxic soluble clumps or the tissue fibrils out of the circulation and out of the tissues to reduce the damage that they're causing to the organs? That is actually being explored quite actively. So here we have a phase 1-2 study of the first therapy that was targeting the misfolded proteins, the fibrils, and the prefibril clumps, and this is called NEOD-001. This is an antibody. It was tested in a 2-part study, a dose escalation part where the antibody was tested in groups of patients at different doses, ranging from 0.5 milligrams per kilogram all the way up to 24 milligrams per kilogram. All dose levels were actually proved to be safe, and ultimately we went forward from this phase 1 dose escalation portion to a phase 2 portion where we tested that highest dose level of the drug in a group of patients with cardiac involvement and a group of patients with renal involvement by their amyloidosis. Now, these were all patients who previously had had chemotherapy, had finished it, had had at least a partial hematologic response, and weren't planning to get more chemotherapy, and would otherwise be followed at that point to see if their organs got better over time. The idea of this study was to see if treatment with the antibody would increase the rate at which organs improved and the likelihood of the organs improving. And so on the bottom we have a group of 27 patients with cardiac involvement, and this is a waterfall plot like what I showed you before, but instead of measuring difference in the free light chains, what we're measuring here is a heart marker called NT-proBNP. When the NT-proBNP goes up, that reflects increasing damage or strain on the heart, and when it goes down, that reflects improvement in heart function. And what you can see here is that the majority of patients had improvement in the heart function, including a large number who had at least a 30% improvement, and that's the definition of a heart response following treatment with treatment for AL amyloidosis. So this looks very promising because this is a higher percentage of patients with heart involvement reaching that 30% improvement threshold compared to what we expect historically. Likewise, in the other group, these are a group of 23 patients with kidney involvement, and we're measuring kidney damage based on how much protein they're spilling in their urine, because that's the result of kidney damage from amyloidosis. And again, a waterfall plot, improvement in protein leakage means a reduction in protein leakage, and that's a bar that goes downward. And you can see here that the majority of patients had improvement in proteinuria, including 4 patients who had complete resolution of protein leakage compared to pre-treatment. So this is both the heart and kidney findings that we see here are extremely encouraging, and you couple that with a real lack of toxicity from this antibody, and there was a lot of enthusiasm about moving forward with this antibody. And so a few different studies were designed and carried out. The first study is called the Pronto study. This is a randomized phase 2 study. Think of the design of this along the lines of what we saw previously with phase 3 studies, but the size of the study is relatively small. And this was a blinded study for patients who had previously had chemotherapy for their AL amyloidosis and who still had evidence of cardiac involvement based on echocardiograms or their NT-proBNP measurements. And they were randomized to either NEOD-001 or placebo. and it was blinded, so patients and doctors didn't know what they were getting, and patients were treated for a total of 12 months, after which point they could continue therapy if desired. But the end point was an evaluation at the 12-month mark. And unfortunately, what we saw here was that there was no improvement in the rate of cardiac responses as measured by NT-proBNP improvement at the end of a year in the NAOD-001 arm. In fact, there were less cardiac responses in that arm compared to the other, even though this wasn't statistically different. We also looked at other endpoints to try and get hints about whether there actually was improvement, even though we didn't capture it by measuring the NT-proBNP. But unfortunately, all the other markers of cardiac function and patient well-being that we tested really did not favor the NAOD-001 arm compared to the other. This was a very disappointing outcome, and it led to an early analysis of another ongoing study, a much bigger study called the VITAL study, which was a trial of chemotherapy, that's Cybor-D, with or without NAOD-001 as upfront treatment of AL amyloidosis. So these aren't patients who previously had chemo and were now getting the antibody. This is the idea of this study, is to combine the antibody with chemo up front to see if it can start clearing amyloid even as you're shutting off the tap with the chemotherapy. And the design of this phase 3 study is shown here. The primary endpoint of this study was what we call a composite endpoint, which was the combination of either of all-cause mortality, which means death from any cause, or hospitalizations for cardiac symptoms. You added both of those together. If a patient had either one of those things happen, they were considered to have hit the endpoint of the study. And we were looking to see if the rate of that combined endpoint was reduced in the study group. There was what we call an early futility analysis to get a sense of what was happening in the study. After the Pronto study came back negative, and even though there was a slight advantage, what we call a hazard ratio of 0.84 favoring NAOD-001, the trial was halted. This was a statement related to the report, and like that commercial that we all see on TV, I'm now going to translate for you what that sentence actually means so you understand it. So the translation of that complicated sentence is this: there was a slight reduction seen in the rate of deaths plus hospitalizations, but we could not mathematically prove that that didn't happen just by luck. And based on how small the difference was in that reduction, in order to prove mathematically that it wasn't, we would need a much, much bigger study than the trial that was designed and ongoing. And so as a result of that, especially in the context of a negative prior study, the decision was made to halt this study altogether rather than expanding the size of it. And that's where this compound is at right now. When these two studies both closed, the development of NAOD-001 was halted. And so the question is, does this put us back to the drawing board in terms of antifibril therapies? And the answer is not quite. There's another antibody in development called CAL-101. This has been studied to a lesser degree. It's only in phase 1 studies. There's been a phase 1A study where patients were treated with a single dose of the antibody, and a phase 1B study where patients were treated with 4 doses. These studies were, in each case, the studies tested different dose levels of the antibody to determine the maximally tolerated dose, but the investigators also wisely did some work to see if they could find any evidence of organ responses, and here's some of the data from this study. 27 patients were treated between the two studies. Most of them had been, the average time since the last time they had had chemotherapy was 6 months. And most of the patients had had a good hematologic response or reduction in light chains from their last chemotherapy. And then the patients proceeded with this treatment with organ responses assessed at week 8 in the single dose study, and at weeks 5 and 8 and 12 in the multi-dose study. What we saw was that there was basically, again, no dose-limiting toxicity, and there were no therapy-related deaths, which was very encouraging. There actually was a little bit of evidence of responses. There were 12 patients with cardiac involvement, and 8 of them had a reduction in the NT-proBNP. There were 10 patients who had enough protein leakage in their urine to be considered as having renal involvement, kidney involvement, and half those patients had an improvement in protein leakage. And then there was one patient who developed an unexpected rash, and when they did a biopsy, it turned out that the antibody was actually binding amyloid that was in the patient's skin that they weren't previously aware was present. So all of these things together make the investigators think that maybe something's happening. It does make you scratch your head a little bit because it looks an awful lot like the phase 1-2 results from NEOD-001. So here we have a little bit of additional information which gives us, I think, even more hope or expectation that this particular antibody may actually be inducing organ responses. This is a slightly complicated slide conceptually, so I want to walk you through it. On the far left is a cartoon diagram of the heart, and I've lifted the top of the heart up, and I'm showing you the bottom 2 chambers, which are called the ventricles. One of the ventricles has a yellow graph overlaid on it in this picture. That's the left ventricle. That's the one that pumps blood out of the heart into the rest of the body. And in amyloidosis, as the heart becomes thicker, the function of the ventricles, particularly this left ventricle, decreases. The chambers become stiffer, and we can measure this using something called strain mapping. If you picture that ventricle with the graph on it, if you picture looking at it from the angle that the arrow is showing you, sort of end on from the bottom, that's the view you're seeing in the middle slide. And the colors that you're seeing overlaid on that graph tell us how well each section of that of the heart in that diagram is working. You can see that the dark red is limited to the tip of the heart, and then lighter colors, including even a blue color at the very tippy top, is seen in the outer segments. And this is a pattern that's very typical of AL amyloidosis. And when heart function is worsening, those outer sections become increasingly lighter and lighter, and then they even change from pink to blue. And when heart function is improving or more normal, it gets darker and darker pink until it's actually red, like the very top. What you see on this image is that those red images are actually lower numbers. They're more negative numbers than the outer ones, and so a lower number is more normal. And what we see in the final panel is in all of the patients who had cardiac involvement, we see the degree of strain averaged globally across the whole graph at the beginning of treatment, and then we see the strain for each patient at week 12 after the patient has been treated. And what we see is that in all cases except one, the strain actually improved, became more normal in these patients. And in case there's some thought that this might just be a coincidence, they did the same analysis in patients who weren't thought to have cardiac involvement, and what they saw was that the strain pattern was stable over time in patients who didn't have amyloid in their hearts. So you only saw this improvement in heart function in patients who actually had amyloid in their heart to begin with. So a very provocative finding, and hopefully it's the beginning of a very promising development for this antibody. Now, I'm going to move out of AL amyloidosis to transthyretin amyloidosis. So, transthyretin amyloidosis is a completely different disease than AL amyloidosis. AL amyloidosis is a plasma cell disease. The abnormal plasma cells form abnormal light chains, and those light chains are what form amyloid. Transthyretin amyloidosis has nothing in common with that disease except that at the end of the day there are protein deposits in the organs. But those protein deposits aren't made by plasma cells, and they're not made out of light chains. They're comprised of clumps of transthyretin protein. Transthyretin is something that's made by your liver. Your liver cells make transthyretin molecules, which we call monomers, and those transthyretin molecules like to form 4-packs or tetramers. This is shown on the far left of this slide. The tetramers are important normal proteins that circulate in our body, and they have a physiologic role in our bodies. In transthyretin amyloidosis, many patients have a mutation in one of their transthyretin genes, and because of that, they make a mixture of normal monomers, which in this cartoon towards the middle are still shown as gray squares, but they also make misfolded monomers, which are shown as pink circles. And when they have the misfolded ones, those misfolded monomers can form clumps. Now, in this situation, the patient's transthyretin also tries to make tetramers, but they're not quite as stable, and so you have these circulating monomers, and then the misfolded monomers get sucked into amyloid fibril formation. And as you can see here, instead of a back and forth between single molecules and 4-packs, what you see is a one-way street. As they get incorporated first into clumps and then into fibrils, you get this sink where the misfolded monomers are turn into amyloid. Now, there are also some patients who don't have a mutation in their transthyretin, but for reasons that we're not entirely clear on, normal transthyretin monomers or single molecules still get incorporated into clumps and then strands. We call that wild-type transthyretin amyloidosis, and it tends to occur in older people, men more than women. And again, the reason for it is not entirely clear, but whether there is a mutated form of transthyretin or not, the principles that I'm showing you in this cartoon are important in our treatment strategy for this disease. So here I'm taking the steps from the right side of the last slide, the steps of amyloid formation, starting from the production of transthyretin monomers, and I'm going to show you how we can tackle each step of this development pathway to reduce the formation of amyloid. So first, one thing we could do is we could stabilize the tetramers. Remember I told you that the molecules that get sucked into amyloid formation are the monomers. So if we could find a way to stabilize them as the circulating 4-packs, that renders the molecules unavailable to be incorporated into amyloid. So there's a class of drugs called tetramer stabilizers. One drug that was just approved by the FDA this month was tafamidis. Now, this is a drug that had previously been approved in the European Union and in Japan, but it was now just FDA approved in the United States. This is an oral medication which stabilizes the tetramer, and in a randomized study, which I'm going to show you here, led to positive results that led to the approval. This is a different phase 3 study. One difference between this and the phase 3 studies I showed you earlier is this is actually a three-way randomization to placebo, low-dose tafamidis, or high-dose tafamidis. And then after 30 months of treatment, patients were able to go on to therapy which is called an open-label extension trial, where all the patients, regardless of which arm they started on, were able to get tafamidis without randomization anymore. This was a 441-patient phase 3 study, and this is a survival curve showing that the patients in the tafamidis arms, and what they did here on the blue curve is actually combine the low-dose and high-dose tafamidis groups and compared it against the placebo group. And what we can see here is that after 30 months of treatment, there was actually an improvement in survival favoring tafamidis. And because of this, this led to the approval of the drug. Now, I did mention here that there is another drug that's also used as a tetramer stabilizer. That's called diflunisal. Diflunisal is actually a non-steroidal anti-inflammatory drug, and it's not approved for this particular indication, but it is an FDA-approved drug. And before tafamidis was approved, some patients were treated with diflunisal as a tetramer stabilizer. As an aside, just going back to AL amyloidosis for a second, it turns out that you can actually stabilize light chains in a way that prevents them from going on to becoming amyloid as well. And this is an example of a preclinical study published by Dr. Morgan, who used to be at the Scripps Institute and is now at Boston University, showing that in the lab, now these are not animal studies, these are not human studies, but in the lab, treatment of abnormally folded amyloidosis light chains can stabilize them in a formation that prevents them from being incorporated into amyloid. So this lesson that we've learned from ATTR amyloidosis may eventually be applied to AL amyloidosis or other types of amyloidosis as well. Now, back to ATTR. Another point in this pathway which we could hit production of amyloid is we could reduce production of misfolded transthyretin monomers. If you could knock out these particular abnormal ones, all you'd be left with were the normal monomers. And if you remember, the normal monomers don't get incorporated into amyloidosis except in wild-type transthyretin amyloidosis. And if you did this, you'd be able to reduce amyloid formation. So the first example of this kind of treatment was a liver transplant. If you took out the liver of somebody who had a genetic mutation that resulted in their liver cells making abnormal transthyretin molecules and replaced it with a normal liver, then that liver would only make normal transthyretin. And there are definitely examples of patients whose clinical course improved following liver transplants. But first, not everybody showed improvement, because sometimes the amyloid that had already been laid down could still seed further amyloid formation, even with just normal transthyretin being produced. Second of all, there are other organs besides the liver which make transthyretin, and you didn't fix the abnormal transthyretin production in those organs. And finally, the biggest obstacle is that most patients really aren't candidates for liver transplant because they're not healthy enough or young enough to undergo that treatment. And that's not to mention the fact that livers are not easy to come by and that there really aren't enough organs to go around. So even though liver transplant can benefit some patients, it's not a universally usable treatment. But what if you had a treatment which could, in a targeted way, reduce the production of misfolded transthyretin in the liver without having to replace the liver? It turns out there are such therapies. 2 treatments have recently been approved in the last year that do exactly this. Now, what this slide shows us, for starters, is just some basics about protein production so you understand what they do. But basically, in a liver cell, the DNA, or the genes inside the nucleus of the cell, form the template for something called RNA. And RNA is the template for a protein. And so when you want to produce a certain protein, you produce RNA for that protein, and that's how the protein's produced. So that's using this system, a cell can modulate the precise amounts of each different protein that they want by regulating the amount of RNA that it makes for each of the different proteins. Now, in this case, because there are different RNAs for different proteins, it's possible to target specific RNAs and knock them out of commission to reduce the production of that protein without affecting the production of other proteins. So, patisiran and inotersen are two examples of drugs which target the mRNA for transthyretin, and by binding it, lead to its destruction, and therefore halts production of the transthyretin protein. This is an example of phase 1 work. This was actually a study that was published in 2013, and it's a group of healthy volunteers, because remember, everybody makes transthyretin, right? And so this is a single dose study of different dose levels of patisiran in healthy volunteers, just to see what would happen to transthyretin levels in their blood following a single dose of this. And what you can see is that once you achieve a certain dose threshold, you get this massive suppression of transthyretin production and a rapid drop in the level of transthyretin measured in their blood that lasted for just about a month in all cases. So this is an extremely provocative and promising result, and it quickly led to phase 3 trials of this drug. This is a trial of patients with mutated transthyretin amyloidosis that was causing neurologic symptoms. So it's called familial amyloid polyneuropathy, or FAP. And this was a study comparing 18 months of IV patisiran versus placebo. You can see here that twice as many patients were treated with patisiran as placebo. That's called a 2-to-1 randomization. And then again, as we saw in one of the other trials, after 18 months of therapy, there was an open label extension where all patients were able to be treated with patisiran. And the endpoint of this study was to look at a measure of neurologic function called the modified NIS+7, which is a scoring system that looks at nerve function, including sensation and motor strength and other aspects. And then there were secondary endpoints looking at all sorts of functional measurements and quality of life measurements. And the primary endpoint in this study actually improved with patisiran. That's pretty remarkable. Prior to this, the best therapies at best slowed down the rate at which the NIS, or the modified NIS+7 score, worsened. But in this particular study, we actually saw that there were some patients who not only had stabilization, but improvement in the modified NIS+7. And this led to approval of patisiran for ATTR amyloidosis with a mutation and neuropathy. The other drug that I mentioned previously, inotersen, was approved using a very similar design. This is a 15-month study with a 2-to-1 randomization against placebo, followed by an open-label extension trial. This trial also looked at the modified NIS+7 as a primary endpoint, and also looked at quality of life endpoints as secondary endpoints. And what we saw in this study was, again, improvement with inotersen compared to placebo, leading to the approval of this drug. One of the attractive things about this drug is that it's subcutaneous, so it's a shot under the skin rather than an IV like patisiran. But there were a couple of side effects with this one, including low platelets, which are the cells that prevent bleeding in a small fraction of patients and kidney injury in a small fraction of patients. And so even though this drug is easier to administer, it does require a bit of additional monitoring to make sure that patients on this drug aren't having that side effect. But both drugs are approved in the United States in the last year. Finally, we could take a page from the AL amyloidosis treatment paradigm and develop antibodies against the amyloid fibrils. And that strategy is also actively in development. The same company that made NEOD-001 has also been working on an antibody against transthyretin called PRX-004, and that is currently in phase 1 studies. So here we see a diagram of the current development plan for PRX-004. The plan is to conduct a typical dose escalation phase 1 portion, looking at multiple dose levels in small groups of patients. And the idea of this part is to identify what we call the RP2D. So as not to confuse it with any pop icons as shown here, RP2D stands for recommended phase 2 dose. And once that's established, then there's going to be an expansion phase at the recommended phase 2 dose. And then after that, there's going to be an extension phase where patients are treated over a longer-term basis. Finally, as a last topic, I want to talk about other types of amyloidosis very briefly, and I also want to use this opportunity to talk about other types of clinical research, including non-therapeutic and observational trials. So there's another type of amyloidosis called leukocyte chemotactic factor 2 amyloidosis, or ALEC2 amyloidosis. And this is a form of amyloid that's seen in certain demographic groups. It's known to be more common in patients of Mexican descent, and there are also other subgroups or other populations that have been shown to have ALEC2 amyloidosis, including First Nation groups in Northwest Canada. And this is a form of amyloidosis which predominantly involves the kidneys. It's not clear that there is any specific mutation that causes this. And it's also not really clear what the actual frequency of this disease is. That is, we don't know how common ALEC2 amyloidosis really is. And so we're conducting an observational trial where we are monitoring on a long-term basis patients who have been diagnosed with this type of amyloid to sort of get a better understanding of how it affects the kidneys over time and perhaps how best to monitor the disease over time. And so in this trial, which is a multi-center trial, patients are going to be followed longitudinally, and their kidney function will be monitored, and we'll be measuring levels of LEC2 protein levels and also LEC2 RNA. The hope is that we may be able to ultimately develop an RNA interference therapy for this specific type of amyloid, similar to the RNA interference therapies inotersen or patisiran that we've already developed for ATTR amyloidosis. The other trial that I'm showing you here on the right is an imaging study. So patients are getting an injection of a molecule called P5 plus 14. It's a molecule type called a peptope, and this molecule is radioactively labeled so that it can be picked up in a nuclear medicine scan. the molecule, the peptope molecule, binds amyloid deposits, and it binds any type of amyloid deposit. So the study that's being done will include patients not just with AL amyloidosis or ATTR amyloidosis, but also ALEC2 amyloidosis and other types. And the investigators at the University of Tennessee are going to be testing the safety of administering this radioactively labeled peptope, but also the usefulness of it as an imaging modality by imaging the patients with PET-CT scans after they've been dosed with this labeled molecule. So to conclude, clinical trials and basic research are really the only way to advance progress in amyloidosis therapy. Antibody therapy has been a real focus of amyloidosis research, and particularly AL amyloidosis research. Anti-plasma cell antibodies like daratumumab and isatuximab and hopefully elotuzumab appear to be very promising. Antifibril antibodies, while attractive, have had some setbacks which have slowed down their progress, but CAL-101 is still moving forward, and hopefully we'll see some movement in that area. In the area of ATTR amyloidosis, there have been 3 drug approvals in just the last year: the tetramer stabilizer, tafamidis, and 2 RNA interference therapies, inotersen and patisiran. And one of the exciting things is that new formulations of the RNA interference therapies are being developed, which will allow them to be administered far less frequently because they'll be longer acting. And also there's the potential for similar therapies to be developed for other types of amyloidosis besides ATTR amyloid. And with that, I thank you. And now I'll be able to answer questions live about anything that I did talk about or any topics that I didn't talk about but which you want to talk about.
Fantastic. Well, thank you so much, Dr. Zonder, for your insights. As a reminder, the text chat is located on the right-hand side of your screen. To submit a question, type your question in the small text box at the bottom, and when finished, click the send button. Please note that due to time constraints, our panel may not respond to all questions submitted. Dr. Zonder, I'll turn it over to you for any questions.
So those of you who have been watching the feed for the over the course of the meeting, I've sort of been fielding questions as they've come through on the feed. And one thing that's come up repeatedly is about use of daratumumab. Obviously, there are many people listening to the call who are on DARA, and other people, most of them want to know how long is it usually given for, and many other people want to know sort of what's the typical usage. So when we use daratumumab by itself, it's given as an IV infusion, and the first infusion is usually quite long. It's usually 6 to 8 hours, and it's given with pre-meds, which almost always include steroids. And that's a question that came up: can you use it without dexamethasone? Yeah, if you're using it with prednisone or methylprednisolone, but it's typically given with steroids of some sort, and that's to reduce infusion reactions. And if the first infusion is tolerated, then the second one a week later can be given a little bit faster, and the third one can be given over a period of about 3 hours, and that's about as fast as we give daratumumab. And the way we use it is we do weekly doses for 8 weeks, and then we do every other week dosing for 8 more treatments, so that's another 16 weeks. That gets us out to about 6 months, and then at that time we go to monthly infusions. In the clinical trial that I showed you, up to 24 cycles of, I think, I don't have the trial in front of me. I believe there's a limit of 24 cycles of daratumumab on the clinical trial. And in that trial, the CyBOR-D plus or minus DARA trial, the DARA is given as a subcutaneous injection, which is like a depot injection under the skin. It's administered more like the way Velcade is given, as a quick injection over just a few minutes, which is a major improvement in terms of convenience. Hopefully we'll see that the efficacy is similar. We believe it's going to be based on what we already know from multiple myeloma, where the sub-Q version's been studied. Are other people able to chime in and speak also? Are they able to just talk and I can hear them, or am I limited to the feed?
Unfortunately, no one's dialed into the phone lines for questions, so only limited to the feed, unfortunately.
Through the feed. Okay, well, I'll answer questions for a bit longer, and you tell me when it's time for me to stop, or I'll just stop if I see the number of participants dwindling to extremely small numbers. But let me start with questions that I haven't answered already. So in terms of any new studies on AA amyloidosis, there is ongoing work in AA amyloidosis. It's not something I've been involved with, and the best place to look for open studies in this type of amyloid would be at clinicaltrials.gov. Next question from Ann Torres is, how do you diagnose non-familial ATTR amyloidosis? Sometimes it can be difficult. The symptoms of ATTR amyloidosis are overwhelmingly related to neuropathy symptoms and cardiac symptoms. Other organs can be involved, but they're not usually as common as these two organs. Usually a biopsy, some sort of tissue biopsy showing amyloid that is typed as ATTR is needed. Fat PET aspirates may or may not be positive, and so sometimes the actual involved organ, specifically the heart, needs to be biopsied. An endomyocardial biopsy is done by means of a heart cath, along the lines of what you do when you're trying to assess for like blocked blood vessels, but instead of looking at the blood vessels, you're actually pinching a little bit of tissue from the inside of the bottom heart chambers. A more recent update on that is technetium nuclear medicine scanning, or PYP scanning, which is a test that was originally invented as a bone scan, but it turns out that hearts affected by transthyretin amyloidosis retain the bone tracer even more heavily than bones do. And so there's diagnostic criteria, but basically if you have increased uptake of the tracer in the heart compared to the bones on a technetium 99 PYP scan, that's actually considered diagnostic for cardiac ATTR amyloidosis without a biopsy. And then if you were to go on and do blood work, which failed to show a mutation in gene sequencing of transthyretin, then the presumed diagnosis would be wild type or non-familial ATTR. I hope that's helpful. The next question on the feed is, can AL be hereditary? The short answer is not really. We know that there are family clusters of patients with plasma cell disorders, so all of us have families in our practice who have multiple people affected by myeloma and or amyloidosis and or MGUS, which is a precursor condition, and sometimes you also see lymphomas in these same families. And so clearly there's a predisposition in some families, but by and large, most patients with AL amyloidosis don't have any affected family members, and so we don't think of it as an inherited condition. The next question are there reasons why some AL patients have excessive gum bleeding, in partial remission of excessive gum bleeding post-tooth extraction? So there's a couple of reasons why patients with AL amyloidosis may bleed. First, occasionally the amyloid deposits soak up clotting factors. Clotting factor 10 is a specific one, and when that happens, functionally a patient is almost like a hemophiliac patient who is missing a key clotting factor, and because of that they can have bleeding. Another reason amyloid patients can have bleeding is that when amyloid affects the blood vessel walls, the blood vessels are more fragile and less able to contract to clamp off blood flow, and so you may have excessive bleeding related to that as well, and that actually is probably the more that is the more common reason why patients with amyloidosis have excessive bruising around their eyes and in the skin. The next question from Natalie G. Is it possible to have increased levels of kappa and lambda free light chains, or are one level, or are levels exclusively increased, meaning is one type or the other? The short answer to this, and I didn't get into it very much, but the short answer is yes. And the most common reason that both may be elevated is abnormal kidney function. The plasma cells make the light chains, and then your kidneys flush the light chains. And so if we took me as an example, if you measured my light chains today, presumably my kappas and lambdas would both be around 1 milligram per deciliter. If we lived out an urban legend and I had my kidneys removed and I was left in an alley somewhere, and then a week later we measured my light chain levels, the kappa and lambda light chain levels would both be elevated. And it's not because my bone marrow is making more light chains than it used to be. I have the same number of plasma cells in my bone marrow, but because my kidneys are now being sold on the black market instead of flushing light chains, the levels are building up in the blood, and they would be building up equally. In amyloidosis, that's actually why the difference is something that we really focus on, because even in that situation where kidney function isn't normal, you might have elevations of both light chain levels, but one would be disproportionately elevated compared to the other. And with successful treatment, the involved free light chain still comes down and it matches or approaches the level of the uninvolved free light chain. So the levels of both might be elevated, but the difference between them should still be very tight if a patient with kidney function has responded to therapy. So I hope that's helpful. The next question is from Jack Hallowell, and the question is, can I comment on the current knowledge of the efficacy of tafamidis versus diflunisal? Not in a particularly informed way, because there has never been a tafamidis versus diflunisal study. In terms of the manner in which they stabilize light chains or the potency with which they stabilize the tetramers, they're actually very similar. Tafamidis has a better side effect profile, so I would say that it's harder for some patients to stay on diflunisal. And because of that, tafamidis is probably going to emerge as the better drug of those two. But if there is a patient who is currently on diflunisal and doing well in terms of tolerating it, it's hard to make a strong argument that they ought to switch to tafamidis. We don't have the same level of evidence about what diflunisal does compared to tafamidis in terms of survival, because there's never been a study involving a few hundred patients with diflunisal. But again, just based on the mechanism of action, diflunisal should be helpful for patients who are tolerating it. Bianca Mir asked a question about AL amyloidosis being inherited, and I think we already touched on that. And then Muriel Finkel mentioned AG10, which is a different tetramer stabilizer that's in ongoing clinical development, and I'm right now I am trying to find out from clinicaltrials.gov where AG10 trials are open. So let's see if I can figure that out. There is a study looking at patients with transthyretin amyloid cardiomyopathy that is currently recruiting, and currently to clinicaltrials.gov. This is open at many, many centers. I just happen to not be one of them. So if you go to clinicaltrials.gov and just type in AG10, you'll see the results of an extremely large randomized study that's open at multiple centers. Muriel also asked the question about the scan he's working on, and that was the last slide that I showed before we moved into questions, which showed the peptope. The peptope, that scan is a very interesting thing. It's to just summarize what that molecule is again. It's a protein that is sticky for any type of amyloid. So it's not specific for one type or the other. It doesn't just bind AL like Cal101 does, or just bind ATTR or some other type. It binds amyloid fibrils in general. And in that particular study, that molecule is being radioactively labeled so it can be picked up on a PET scan. And so the study is looking at localizing where amyloid is in somebody's body using that peptope molecule labeled in a way that a camera can find it. The other thing that he is doing, which is interesting, is he's using that same platform as to do something called pre-targeting. One of the listeners on the lecture asked me before about whether Cal101 can target any type of amyloid except light chain amyloid, and the short answer is not by itself, but this same lab at University of Tennessee can attach a section, can modify the end of this peptope protein so that it serves as a target for whatever antibody they want it to, and then they can use it to basically effectively coat amyloid fibrils and then bring antibodies that wouldn't normally bind those amyloid fibrils into contact with them sort of in a secondary way. And there's been some interesting work showing that he was able to make AA amyloid, ATTR amyloid, and cases of AL amyloid which weren't binding Cal101 strongly. He was able to show that he could make that antibody bind to any of those fibril types using this peptope as a pre-target. Very interesting work. How much time do we have left in terms of questions?
We can go probably another 5 minutes, Doctor, but if you need to go, then that's purely up to you as well.
No, we can do 5 more minutes. Wow, there's a lot of questions here. So one question, why aren't inotersen and patisiran used for ATTR wild type? It seems like they would work. Right, that's absolutely true. It does seem like they would work. And we know that because of the phase 1 healthy volunteer study showing that even normal transthyretin, which is basically what wild-type ATTR is, right? Even normal transthyretin is reduced by these molecules. So the reason they're not approved for this condition is because the studies that led to the approval specifically targeted patients with mutations and neuropathy. So now there is going to be ongoing work looking at these agents and also next generation agents made by the same companies that have different chemical features that allow less frequent dosing, for instance, or subcutaneous dosing instead of intravenous dosing. Those studies are going to be ongoing, and certainly RNA interference therapy is going to be developed for mutated, familial cardiac ATTR amyloid, and also eventually wild type as well. So there's another question here from Linda Edelman, and I'm sorry that I'm skipping around a little bit, but I only have a few questions, so I'm trying to find questions about things that I didn't talk about. There's a question from Linda Edelman about isatuximab. Isatuximab is a different CD38 antibody, and all I can say is we're seeing responses in the isatuximab study along the lines of what we saw in the daratumumab studies, and that's what we expected based on the efficacy of the antibody in myeloma. CD38 is the same protein target that's the target for daratumumab, so this is basically a competitor antibody that targets the same protein. A question here: as a patient with AA of unknown etiology, where is the best place to go for latest treatment options? No one can find the root cause, and I continue to decline. I'm running out of time. This is from Elaine George. And what I would say is, that's your situation is the type of case where, a place like Mayo Clinic, which not only has a strong amyloid program, but also is strong across multiple medical disciplines, including infectious disease and rheumatology, which are the two classes of disease that most commonly cause the inflammation that underlies AA amyloid. That's the kind of center you want to go to for that condition. And I think I'll try and field one more question, and I guess I'll finish up with one more patisiran question. Is it recommended that patisiran be used alone or in concert with a stabilizer? From Linda Barillo. And what I can tell you is that there's tons of interest in doing that. The main obstacle to that is going to be cost. And the RNA interference drugs cost something in the neighborhood of $400,000 a year, and tafamidis is not going to cost that much, but it's going to cost a lot. And so when you're looking at combined therapy that's $500,000 or $600,000 a year, that's a hard thing to study. So we're interested. Everybody's interested in that possibility. It seems like knocking down RNA and transthyretin protein production, and then stabilizing the protein that is produced in a form that can't be turned into amyloid. That seems like a winning combination, but right now there is no great data about that strategy. Since it's 5:10 and I think I used up my 5 minutes, I'm going to wrap it up and let everybody go. Several people have asked me about the slides, and I'll respond to those people who did and get you copies of the PowerPoint. I'm happy to do that. Thanks.
Perfect. Thank you so much, Dr. Zonder. On behalf of the Amyloidosis Foundation, I would like to thank you all for your participation in today's event. A post-event survey will appear requesting your feedback, so please take a moment to complete this survey, as it will help Amyloidosis plan future web events. This concludes today's program. Thank you all, and have a great day.